Hi everyone, I'm Dr. Brooks. Thanks for giving me the opportunity to speak. So I'll be presenting on the dual RF and anti-CCP seropositivity status in patients and how that affects their mortality, disease flares, and the presence of erosion, so breakdown of your joints on x-rays. And so essentially, when we're thinking about seropositivity, this has to do with two markers in rheumatoid arthritis, which is rheumatoid factor and anti-CCP. It's a common blood test that you get drawn at the beginning of your diagnosis with rheumatoid arthritis to guide treatment. And so how we completed this study is that in Mayo and Rochester, we have access to a large database that encompasses 8 counties within Minnesota. And so we looked at patients from 2003 to 2019 at their time of diagnosis with RA or within 1 year of their diagnosis to see their status of either having or not having rheumatoid factor and anti-CCP. And what we found is that in all of the so there's 4 different cohorts, those that were negative for both RF and anti-CCP, those that were negative for RF and positive for anti-CCP, those that were RF positive and negative for anti-CCP, and those that were positive for both of them. And all cohorts were in their 5th decade of life. The majority of the cohorts were non-Hispanic white females, and they also about half of all cohorts had a smoking history, with the highest being in those that had seropositivity, so having both of the markers was 60%. And so then we're looking at our outcomes, disease manifestations at the time of diagnosis or within 1 year. So when we're looking at radiographic erosion, so that breakdown that we see on x-rays, that was highest at 28% within our dual seropositivity group. But it was also about 1/5 of patients who didn't have either of their markers or only had rheumatoid factor or also had evidence of erosions. When we're looking at the visits for a flare, so when you come with a flare of your rheumatoid arthritis, that was as expected to be highest in our patients that had both of the markers, but then it was also very high in patients who only had rheumatoid factor. And then baseline ESR, so erythrocyte sedimentation rate, is a marker of inflammation. And this was relatively high in all of the groups, with the highest being within the patients that had both of the markers. And then when we're looking at medications here, commonly patients are first started on methotrexate for their rheumatoid arthritis. This is really dependent based on their clinicians assessing their disease activity. But we can see that in the patients who had dual seropositivity, so both of the markers, that was 78% of them were prescribed methotrexate, and the lowest was in the patients who only were positive for rheumatoid factor. Now, where this gets really interesting is when we're looking at mortality. So mortality is a measure of survival in patients. And so when we're looking at patients who had anti-CCP only positivity, they had a 27% increase of mortality. So that's saying that they have a decrease in their survival. And then when we look at patients who were positive for both of their markers, they had a 70% increase in mortality. Now, when we look at patients only positive for rheumatoid factor, we find that there's over a 2 times increased risk of mortality. And so this when we're thinking about when your physician originally diagnosed you with rheumatoid arthritis and they were looking at both anti-CCP and rheumatoid factor, so anti-CCP is more specific for the diagnosis of rheumatoid arthritis, and rheumatoid factor can be positive in a lot of disease states, not specifically just RA. It can be elevated in patients who have different cancers or just other inflammation, infections that are occurring too. But what this suggests is that RF seropositivity, so being positive for that, could be independently driving mortality in our patients with RA, and that there's not a compounded effect where if you have both anti-CCP and rheumatoid factor, you're having a huge increase in your mortality. Part of this could partially be because there is a slight delay in the initial treatment of patients who are only positive for rheumatoid factor, possibly because the physicians are looking at other diagnoses that could be driving this inflammation. Maybe they don't have the characteristical clinical presentation of it, but that will require further investigation.
Wow, thank you so much.
You're welcome.